This is an exciting time in gynecological cancer. We know that in terms of therapy, we're making very slow progress, but in terms of prevention, I think we're making very rapid progress. The areas that I want to cover are the prevention of ovarian cancer, the use of exercise in the prevention and the management of cancers, surprisingly, the use of HPV DNA testing for diagnosis and surveillance of cervical cancer, and finally, briefly, talk on the use of non-covalent vaccines as preventive strategies for cervical cancer. Now, we are now clear, I think, that removing tubes and ovaries, particularly in women with mutations, substantially reduces the risk of them getting ovarian or peritoneal or tubal cancer in the future. The issue, however, is salpingectomy. Does salpingectomy itself reduce the risk? And certainly from very large cohort studies, this looks to be the case. Either unilateral, but preferably bilateral. Downstream then, most of us are now recommending bilateral salpingectomy, but our recent studies in Melbourne and our own hospital have just sounded a little word of warning, and that is that in about 10 to 15% of cases, if we look at the tubal-ovarian interface, we find that the tube is stuck onto the ovary, is almost integral to the ovary, and so complete salpingectomy may not be possible. So look at the residual ovary after you've done the operation. If there is a residual fimbriae on the end of the ovary, then diathermy to make sure there's no residual epithelial tissue. Now, exercise is an important area for me. I think we now have the information that if we exercise, our chances of getting cancer are reduced. And furthermore, for our patients, if we recommend exercise for patients with endometrial and definitely ovarian cancer now, we probably reduce their risk of recurrence. So this should be a lifestyle intervention for those patients. I think there is now great data that having a 5-yearly smear test, but utilizing HPV DNA instead of cytology is a much better way of reducing the risk in the future of developing an invasive cancer. And then lastly, for primary prevention, the data is now good that vaccination not only reduces the risk of high-grade abnormalities, but we are now, I think, beginning to see further on the risk of cervical cancer developing. And the non-covalent vaccine has been introduced recently. It's a 9 viral subtype vaccine, and because of that, I think this is going to be more effective. Exciting times in cancer prevention.